Good afternoon, and welcome to this webinar entitled A 3-Year Course, Implementation of Point-of-Care Ultrasound Training within Internal Medicine Residency Programs, presented by Dr. David Tierney. The AIUM is accredited by the ACCME. This webinar is designated for one AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to understand the internal medicine residency point-of-care ultrasound landscape, understand logistics of program implementation, and understand basic methods for resident and faculty training. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to this activity. David Tierney is a clinical advisory board member for Bay Labs, Echonews, and Philips Healthcare. Darcy Belito de Luna has no disclosures. At the conclusion of this webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time he will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now I'm pleased to present Dr. David Tierney. And Dr. Tierney, we can't hear you. There we go.
All right, very good. All right, thanks everybody for joining us. Let me just start by saying that I'm going to give you hopefully an overview of how we do things, how we've done things, what the national landscape is, what the future may look like, try to show you why moving point-of-care ultrasound training into residency programs for medicine is the future. And at the same time, I just want to make very clear that how we do things here is not necessarily the way everyone needs to do things. So a little bit of where I'm coming from, I think, is important here as we move into this talk, just so you know what this place is, where the IMBUS program has been developed. Because the locality, the size of the hospital, where residents go out of your program, the politics within a spot, the resources that are there, all of those aspects are going to determine what an internal medicine point-of-care ultrasound curriculum and program is going to look like, and it's going to look different in each residency program. So I sit in the largest hospital in the Twin Cities. It's about a 700-bed hospital with about 75 intensive care unit beds. It's an academic teaching hospital. We teach medical students and fellows from the University of Minnesota. We have a single in-house residency program for internal medicine here. That's a 30-resident program, and it's the only residency within the walls of Abbott. There is a ton of cardiac fellowship activity on site. We have our several cardiac fellowships here. So you'll get a little bit of a flair that we do a lot of cardiac point-of-care ultrasound. And it's a hospital that has a huge medicine faculty. And one ring beyond the medicine faculty is a group of 75 hospitalists. So it's a huge hospitalist group within the Twin Cities. And then in addition to this single site training program, where our residents spend all of their time, we have 2 main outpatient clinics that our residents and our faculty spend time at. So that's a little bit of the landscape of where what I'm talking to you about and how we've done things comes out of, and hopefully the rationale for why we do a lot of those things. Let's talk about the landscape nationally before we begin, and let's kind of look to our left side as residency programs at the undergraduate medical education world. And this is a list scrolling of medical schools in the US that have ultrasound education in their curricula. In 2015-16, the curriculum inventory from the AAMC, about 75% of schools that participated reported some ultrasound training for their medical school. And as time has gone on, the number of medical students, the number of people from education involved in ultrasound communities across the country has really skyrocketed over the 5, 6, 7 years prior to today. One of the huge organizations that's been at the core of that has been SUSME, and that's the Society for Ultrasound and Medical Education. And one of the core sort of entities of where this community has come together over the years has been the World Congress for Ultrasound and Medical Education, which was in Montreal last year and is coming up at Wake Forest shortly this year. So there's a unique sort of undergraduate push that has always been a part of this, and the prevalence of ultrasound training sort of to our left side, if you will, in the undergraduate world has been prominent and is growing rapidly. Let's look maybe to our right from a graduate medical education standpoint and look at sort of the end result of where residents go to fellowships, things like intensive care unit medicine, rheumatology, pulmonary medicine, areas that are adopting and really leading a lot of point of care ultrasound. So residents are using point of care ultrasound where they end up after residency. And the societies that really drive a lot of that and that are at the core of the CME and the postgraduate world of trainees have really been active recently. This slide shows a variety of pieces. You'll see in the center of this slide up at the top, this is the position statement from the Society of Hospitalist Medicine that will be published here in 4 or 5 weeks or so, talking about point of care ultrasound for one of these niches where medicine residents go into the hospitalist realm. ACP, AIUM, SGIM have been internal medicine organizations as well and have really pushed this. You'll see a lot coming from those organizations going forward as well around the topic of internal medicine point of care ultrasound. ACP just recently released this series of points in the bottom left of this slide. So there are a lot of places once people leave residency and the societies that drive that that have really become involved recently. Finally, there's us in the middle and the Alliance for Academic Internal Medicine, AIM, and the program directors, APTM meetings. These groups that really are sort of centered around us with ACGME are also rapidly moving, and we can expect as sort of the middle group here, with CME and postgraduate groups on one side and undergraduate medical education on the other side, both being very active. I can assure you that us in the middle, this missing link, the graduate medical education piece, especially internal medicine residencies, will have support in the very near future and some guidance from our societies as well as to how to do this. So that's a little bit of the landscape out there. Let's talk about what's our job in this middle missing link portion at the graduate medical education standpoint. And the job is a big one. It's a pretty big mountain here to climb to become competent in point of care ultrasound. And part of the rationale behind why it's big is that it's got a huge cognitive component to this. There's an intellectual knowledge aspect to it. But in addition, there is a pretty big technical, spatial, 3D acquisition of images aspect to this that not necessarily internal medicine residents came to residency thinking they were going to need, unless they were really procedurally oriented internists are not always technically 3D spatial hand-eye coordinated. So there's that aspect of competence as well. It's a cognitive and a technical acquisition piece. And then finally, to be competent in point of care ultrasound, there is a very big clinical, experiential clinical medical knowledge aspect that overlays all of this. So if we look at what we have to do from a residency training standpoint, if our goal is to put out residents who are competent in point of care ultrasound for internal medicine, at the very bottom of this, and it's not necessarily the bottom, but at the base, there is a basic knowledge aspect of point of care ultrasound competence. That's about physics, that's about knobs, how to run a machine, that's about artifacts that show up on ultrasound, and that's at the core of kind of everything that lies beyond that. There is sort of a combined overlap area that has to do with the hand there, the acquisition piece intimately combined with the interpretation piece. So teaching residents how to acquire images in an efficient way so it doesn't take 3 hours, but they can use it in their clinical practice. So efficiency of acquisition, accuracy, and then interpreting what they're seeing on a screen and really interpreting it based on what they see, but also how good is that image we got. So not over-interpreting things that are really tough images and sort of those nuances and the pitfalls that exist within point of care ultrasound are imperative to this sort of middle section that goes into competence. And then finally, there is the clinical integration aspect of point of care ultrasound competence, which is the most essential. You cannot be competent without this. And this takes some time to develop, and it takes a clinical theater to develop it in. Can't be learned in the classroom or with web resources. It really needs to be learned clinically. So how do we get up this? There are lots of courses out there. There weren't 15 years ago. There are a lot of 2, 3, 4-day courses, 5-day courses out there. And those courses in point of care ultrasound, whether it's for faculty or residents, get you, a quarter of the way, an eighth of the way, a tenth of the way up this curve. It gets you the basic knowledge. It gets you some experience with acquisition and a little bit with interpretation. But you're really acquiring images on non-clinical patients. They're skinny medical students about 80% of the time. They're not patients with a BMI of 35 or 40 on a ventilator with chest tubes in. There are certificate programs that have popped up, and certificate programs get you a little bit further. They take a little bit longer than 2, 3, 4 days. They can take months to a year to complete. They almost always integrate courses that gets you those bottom pieces. And then in addition to the acquisition and interpretation training, they almost all have some you've got to go back home and do it at the bedside. So some of the interpretation and integration grows out of certificate programs. The key with both of these is that you may get a certificate from them. Those certificates are certificates of finishing whatever it was you did. And both from a training standpoint and from a medical staff standpoint, those certificates don't represent attestation of competency, if you will. So the last piece here is how do you get to the top and how long does it take? And to get to the top of this, and especially to eclipse that clinical integration aspect of things, it takes years. It's not a months thing, it's a year, 2 years, 3 years sort of endeavor. And that is really why we've got a niche that we need to fill from a residency standpoint. This is a statement somewhat paraphrased from the Society of Hospital Medicine publication that will be coming out soon. And truly the best way to achieve all of these things longitudinally in a clinical environment is with hands-on mentorship at the bedside over a span of time. And residency programs are really the best equipped venue to fill those criteria. Let me put this alongside something because someone's going to say, all right, what the heck is that climb worth? Why would I embark on that? It's a big climb. What's the value in it? And this is a little bit of a adapted piece here from Dr. Soni, a past publication of his. But if you look at the other option, which is, let's just refer to ultrasound. to formal ultrasound to radiology. What do we get and what do we lose? And what you get is the internal medicine physician at the bottom here has to have the basic knowledge to know what question am I asking about my patient and which ultrasound test should I order. There is then a separation in space and time to another expert, an ultrasonographer, who is going to come and acquire the images and then choose out of those images he or she acquired which ones to pass to another space and time, radiologist typically, who's going to interpret those. And then cross one more space and time back to the person who asked the question, who knows the patient, who's at the bedside, some interpretation. And then that person needs to integrate that interpretation with the other stuff and act on it. And that's referral ultrasound. It's great, it's imperative. It has to be part of our clinical practice to do safe and efficient medicine and high quality care. But there are 3 arrows here that jump space and time. In order to avoid those arrows and to reap the benefit of point of care ultrasound, which is a different but intimately tied entity at the bedside, the physician at the bedside who's asking the questions and ordering the tests then also has to know how to acquire them, how to interpret them, how to not interpret things, and then has to know how to integrate that back in. But the key here is that all of those steps remain within one person's hand. That decreases time, typically doesn't change space, and the person who knows the patient and knows what's going on clinically is modifying each of these stages. The other benefit is that if there's a question at the end, or you did something, you acted, you gave a fluid bolus, you can go back and take a look and see what the outcome of your intervention was. So that's the rationale behind the climb, I guess, is that there is a distinct advantage in some areas to point of care ultrasound, but never leaving behind the formal referral ultrasound, which is imperative to be tied intimately with point of care ultrasound. So let's talk about, if that's the big picture, why are we going there and what do we have to get at? What does a curriculum look like? And this is going to be different for each place. Okay, so let's start with just some core aspects of what you need to entertain for, should this be part of our curriculum at our residency program. And at the core and at the starting point for a lot of medicine residencies is procedural guidance. This has become an evidence-based, extremely evidence-based venue of point of care ultrasound, has become best practice in many areas, central lines. And what happens here is this is a big piece of not only procedural ultrasound for resident trainees, but also becomes sort of a surrogate to the diagnostic areas of pleural effusion and ascites and the complications that go along with it, pneumothorax identification. So procedural ultrasound guidance, depending on where residents go out of your programs and what procedures look like in your programs, can be a very nice entry point that is procedural, but is also internal medicine, diagnostic, ultrasound at the same time. The next piece that we do all day, every day, and we try to teach in a lot of different ways, is to impart an understanding of physiology and anatomy, both to residents and medical students, and do this at the bedside, and try to impart things like fluid responsiveness and leg raise and these aspects that we deal with from day to day. And ultrasound is a really, really nice tool for both of those aspects in a training environment of trying to understand anatomy in real time and in the patients you're taking care of, and also to understand the physiology of what's going on and seeing response to your interventions. Other areas to think about when you're developing a curriculum is traditional physical exam. And we are not forgetting about traditional physical exam at all. It's an imperative part still of our training, but the ways we teach it are a little bit different. This is not, do you feel a liver tip? And someone says yes, and I say okay. I don't really have any idea whether you felt that or not, but if we put a probe right next to your finger and I'm looking at what you're feeling, and you feel that little tip of a liver slide under your finger right when it comes across the center of the screen, we both know what a liver tip feels like at that point. And you can't hear this, but cardiac auscultation is a very nice addition to that. Do you hear that mitral regurg murmur? Yes or no? I don't really know. We've got electronic stethoscopes and other aspects, but being able to see at the same time that we're examining with stethoscopes in hands is a really nice tool to be able to improve the speed at which we get better at traditional exam maneuvers. Another area to then juxtapose to that is what areas of traditional exam should move out and be replaced by better test characteristics, more feasible exam maneuvers with point of care ultrasound. And this is the future. I think it's not practical to say we're going to do a full traditional exam and a full ultrasound exam. So as time moves on, we replace things with better things. And this is a table from primary care general internal medicine ultrasound paper that was published that really juxtaposes nicely the traditional physical exam test characteristics with ultrasound. And there's a lot of things that we do better when we use ultrasound. Two last pieces about figuring out what am I going to put into a curriculum. This one is about an essential component of education that I think all of us know who teach day to day, that there's a huge part of learning that has to do with intrigue and this idea of discovery. And this is a slide that sort of harkens to being back at the bedside, a return of internists to bedside medicine and diagnosis. And up in the upper left there, that's an old Rembrandt from early 1600s, the anatomy lesson of Nicholas Tulp, and the intrigue of being able to see inside. And then this is a old but not posed image from one of our ultrasound boot camps with residents who are fascinated by looking inside again. And there's a lot to say about physicians, residents, and medical students and 65-year-old attendings about being excited about being back at the bedside. And then finally, when it's done right, this is all much bigger than diagnostic accuracy and skill development and teaching. In the end, it can truly be about what really matters for internists. It's that relationship. It's about teaching patients. It's about patient understanding of their disease, explaining things, and the satisfaction that can go along with that. So that's a broad sort of overview of what things to consider when you are putting together a curriculum for a residency program. And I put ours here much as a reference for what we've landed on over the last 8 years of the IMBUS program, pieces we've added and taken out, pieces that we think meet those criteria for what's important for a point of care ultrasound curriculum. And it's a big curriculum. It spans inpatient and outpatient aspects of those areas for internists, a lot of heart and lung, belly exam, soft tissue ultrasound. We do a lot of sinus ultrasound here in Minnesota in the fall and the spring and the winter when allergies and I've got a sinus infection, doc, and I need antibiotics pops up. So there's niche pieces of curriculum that just make sense where you are. And the goal is not to have a standard curriculum, but to be able to add and remove things that make sense. So what does this get us and what do we use in the end? This is just where this data is going to come from. So we do somewhere around 3,000 patients per year in the IMBUS program, individual patients, unique patients, and those patients have 2 or 3 or 4 exams done on them. So anywhere from 10 to 12,000 or so exam areas done. So a cardiac exam and a pulmonary exam on a patient over the time. So this is a big volume that then brings us to how does it break down from the areas of the curriculum. The lion's share of what we do is pulmonary and cardiac ultrasound, and surprisingly, the largest component is pulmonary ultrasound, an ultrasound that you can't really order most of the time, depending on radiology departments, at least in the United States, but is our biggest area, both inpatient and outpatient for how we use point of care ultrasound. The other areas, abdominal ultrasound, HENT, so most of that is sinus, vascular, DVT, AAA screening, musculoskeletal, mostly in the knee and the shoulder, and then soft tissue abscess, foreign body, sort of make out the rest of this pie. But the lion's share sits in the hearts and the lungs. So if you're going to say, I got to start small and I need something to focus on at the beginning, those two areas are probably your core central starting spots. All right, let's talk about a few actual nuts and bolts here of how to put together a program. And again, I'm going to show you how we do this, what we've settled on after 8 years of tons and tons and tons of trial and error, and just give you some pieces that I think are important regardless of the program, and a couple pieces of just here's how we do it. So an imperative got to be sort of piece from my standpoint is training the faculty first. And this could be really, really tough because medical students and residents are super excited about this. And I'll show you the timeline here of the IMBUS program going back to 2011 when we truly started the full program here. And what we did first is we took our core faculty that included the Director of Medical Education, who was in his 60s at the time. It took our program directors, associates, and head. It took our outpatient clinic directors, took some key hospitalists, our chiefs. It took the ICU director and cardiologist. And that's where we started. And of all the things I tell people when I talk to them about how to do this, that is the key. We took a year and a quarter, a year and a half to train our core faculty before we touched residents from a training standpoint. So that is really, really, really key. And I'll show you why that's important going on. And then over the 8 years that followed that, every year we train a new batch of residents and bring them into a 3-year curriculum. And we trained additional staff physicians. We have a few one-offs that have been trained here. We telecardiology nurse practitioners up on the Iron Range in Minnesota who do telecardiology with the cardiologists down here in the cities, but can send them a ultrasound exam rather than I didn't hear a murmur up from the Iron Range. So at the core of this is your core faculty, and that's where it's got to start. And as we talk through this, think about not just your inpatient faculty, but also your outpatient medicine clinic staff, which is a really important piece that should follow along. So at the start, before you can train faculty, you got to find that one person or two people who are going to be your champions in this training program going forward. And 10 years ago, there weren't many lucky finds. Lucky finds exist today if you can find someone from a residency program who's had really rigorous training. If you can find an ICU doc who decided to go back to internal medicine, but you got to find someone who's got the skill set. And most of the time, it's not a lucky find of someone who's got 90% of what it's going to take. And you're dealing with someone who's got some skill. They've got maybe an ultrasound background or an ICU background or a procedural background, but you've got to move them to the point where they can truly be your leader at the start of this. And what it usually takes is a combination of things for internal medicine. There's lots of ways to move someone from left to right on this slide. There are a couple fellowships out there. OHSU in Portland has an internal medicine point of care ultrasound fellowship. University of South Carolina has one as well, and the University of UPenn has some internal medicine spots within their ED fellowship. So there are some fellowships out there. They're rare and they're far between. Most people say I need to assemble a few things together, and they do some local and national courses. They do this over time. Our societies, Society of Hospitalist Medicine and ACP, both do great courses for internal medicine, point of care ultrasound, locally and nationally. There are certificate pathways that have popped up, CHEST and Society of Hospitalist Medicine. And then there's people who say, you know what, I've got enough resources around me at home. I've got a radiologist and ultrasonographer and an ICU doc and a couple ED docs who do this, and they're all interested and willing to help out. So let me take that and let me add in some web-based resources, of which there are tons, to try to assemble a package to move forward. So there's a lot of different ways to develop that person in the middle, and it just depends on who they are and what you've got. The biggest key here is the far right of this slide, that once you've developed someone, they've got to have some support around them to truly be the champion from a residency standpoint. And that means something other than their life tied to RVU generation. They need some relief from those clinical requirements. They need a budget to do this. Depending on where people are, the politics around this need some support as well. So here's how we trained our initial 12, okay? And when you think about this, think about who are the trainers I have to train the other people. And at the start, it's almost always a bottleneck of 1 or 2 people who can do the training. So in that initial phase, what we did and what most places I think that do this successfully have done is they take their core faculty and they take 1 topic a month because you're limited in the ability of your hands-on mentors at the bedside. There's 1 or 2 of them across a group of 10 or 12 learners. So take cardiac 1 month, and for week 1, just do the parasternal lawn axis. And then when those clinicians are at the bedside seeing their patients and they want to do a heart exam, just do a parasternal lawn axis. And that can spread out a 1 or 2 or 3 person mentor to a group of faculty and do it feasibly. This obviously takes months then to cover the core areas and get a core faculty trained. Once that initial NIDIS group is trained, then you have the ability to put 1 of them at each of these beds within a room. And you can change your training model a little bit because you've got no longer a 1 or 2 person hands-on bedside mentor and faculty bottleneck. And the way we do this here is the inpatient faculty, we do a 2-day hands-on course, and there is a lot of cognitive involved in that. There's also a lot of hands-on involved in that 2-day course. What we know over the years is that if that's the end of it, and then you release your faculty to do as they wish, with a lot of hope in them, not a high percentage get to the endpoint that you're hoping for, which is really good clinical hands-on experts. So what we've changed to doing is after that course, in groups of 2, once a week, or for a 1-week period from 8 to 4, 2 learners and 1 hands-on faculty spend the week doing nothing but ultrasound on clinical patients in the hospital. And we've got a list put together that cardiology, intensive care, and hospitalists put patients on with findings. And that group of 1 mentor and 2 learners goes from bed to bed to bed and examines 3 or 4 areas on 10, 12, 14 patients a day. And by the end of that week, that's juxtaposed to the end of the 2-day course. They have gotten over that sort of reps hump. That is really important to be efficient enough to be able to do this within their routine daily hospitalist schedule. There's an outside group that isn't faculty, but are hospitalists, and we do the same 2-day piece for them so that they understand the nomenclature, they understand the pitfalls, all of those aspects, but we don't make them all go through the additional hands-on. And what it does then is it lets them self-select a couple people out of that group that say, you know what, I really want to climb this next step here, and I really want to get good at the hands-on aspects of point of care ultrasound. But it doesn't try to move the entire group because that fails most of the time. And then finally, from a attending faculty standpoint, think about the inflow and the outflow. So the ED docs who admit a patient and hand out a patient to the hospitalist, and then the intensive care unit doctors who you hand off to, and the consultant, the cardiologist who you ask to come and look at someone. There has to be a uniform language and understanding about what point of care ultrasound is, sort of from the admission to the inpatient consults to the discharge, and think about who in your institution is important to train from that standpoint. For us, it was the intensivists back many years ago. It was the rest of the hospitalist group, and then it was bringing cardiology on board and understanding the role of this. And then out of that core group, think really hard about making sure some of your core outpatient faculty are involved, because they will then be away after that point. And the outpatient clinic faculty development is kind of a separate track just because of proximity a lot of the time. So you need a core 1 or 2 people that can then, over a long period of time, take 1 or 2 outpatient faculty members and really train them longitudinally in an outpatient practice. If they're not part of that initial core faculty that you've trained, it's tougher to do this. All right, the residents don't necessarily come at the end of all those slides, but somewhere here after you've trained your core faculty, the residents can start to come in. And here's how we do this. We do not during orientation week, not during the first block of residencies when they're still trying to figure out how to log into Epic, but next week is IMBUS boot camp, and we take all of our interns off their rotations. The G2s and G3s cover, and they have a week-long ultrasound boot camp. We have plenty of faculty to be able to staff the beds, 2 interns to 1 faculty. And this is a intensive week of tons and tons and tons of hands-on mixed with didactic aspects and image review. And this is at the core, and this is their starting spot. When you're done with this, you've got barely a learner's permit from our standpoint, but this is an imperative piece to getting the ball rolling. Other aspects we found really valuable. We have a mandatory first-year procedure and ultrasound rotation. So this is an intern in a 1-to-1 rotation with myself and 2 other hospitalists who run the procedure team here. And this is a rotation that all the residents do in their first year. You do a ton of simulation-based procedural training. You do a lot of procedures, all ultrasound guided on this team. It's been around for 12 years or so. And this team also acts as a ultrasound consulting team for the intensivists were bronching a patient on ECMO and wanted some guidance as to where they thought we should go. So this team acts as a consult team for those ultrasound needs within the hospital as well. We have an advanced outpatient ultrasound rotation. You've seen ultrasound pop up a couple times here, and it's really, really, really important to not let this be just an inpatient thing, because when your medicine residents go to the other quarter or third or half of their training in the outpatient environment, they say, that was this tool I'm supposed to develop a skill in, replacing some of my physical exam, but it's not here in the outpatient world. And that really devalues it, and it makes it tough for a resident to latch onto it as an essential tool and really engage in learning. So we have an advanced outpatient ultrasound rotation as well that's mandatory in the second year. And this is all outpatient medicine. Ultrasound. Pneumonia looks very different in the outpatient setting. Ultrasound's not nearly as sensitive probably as it is in your vented pneumonia patient in the ICU. So understanding that from a training standpoint is important. We have a lot of people who do an ultrasound elective, and every couple of years we have a chief typically who stays on for an additional sort of non-official fellowship year. This is one of our pseudo fellows, Trunk, who's a primary care doc up in Fergus Falls, Minnesota, in a small town, and got a skill saw and some charcoal and an ultrasound in there, and international teaching and a lot of aspects that come out of elective rotations. Finally, the most essential piece to this is that it's got to be expected, and it's got to be used not on specific rotations and during courses and boot camps. It's just got to be the way it is, and it takes a while to get here. But if a patient comes and presents a patient with shortness of breath, and in their exam they don't present the lung and the heart ultrasound and the IVC mixed right in with whether or not there was edema and whether they heard a murmur, it's just not okay. And it's become expected that that is a part of the day-to-day. And that has to be the majority for residents to engage in this. They have to realize that it's actually important. It's not just a gadget. And this part of things really can't happen without a trained faculty. So that's a big piece as to why that has to be first. When they use it on their own patients, they see a big difference. Let's talk about a few resources that really aim at quality and safety. Our clinical workflow here is we have a group of 6 or 7 ultrasound faculty mentors on each day. A resident will send a group text to the group of ultrasound faculty. One of us will always be around and free to do it. We'll come down to the emergency room in this little text here and come and do it. It's a group text, so everyone knows that someone's going. We know what it is. If some of us do niche applications and not others. A faculty goes to the bedside with the resident, so every exam a resident does until they're certified in the area is done with a faculty member at the bedside. That's not always practical, but it's the way we do it here, in large part because we developed a huge faculty before we did residents. Do the exam at the bedside, and then we come out and we discuss it. It gets integrated. How are you going to use this clinically? And a piece that's important is some way for residents to record exams, a logbook if you want on paper in a notebook. It can be a Google Doc, but they have to have some way to record. And the way we've done it here is with an application we built, and the resident, when they come out of the room, we use our phones for our pagers. So it's in their pocket, they'll log in. The application knows where they are, so we track where these clinic ultrasounds or hospital ultrasounds. The staffing physician gets credit, so they put in a staffing physician here into the tracker. And then you're going to see when they go in and record what they did. It's not just that they did a cardiac exam. We care about what they've seen over the time. It's not just 100 normal hearts, but they've seen some abnormals, and their abnormals are distributed across what we think is important. And then they submit that exam. When they're done, aiming towards a certification slide that's coming here, they can see what they've done, how many of each exam type, what they're certified in, what they've met minimum criteria for, but haven't yet been certified, and what they haven't met minimum numbers for. So that's a tracking and ability for them to see. It's an ability for us to see from a program standpoint as well, whether this is a Google Doc or whatever it is that you're recording on. You can see trends, you can see overall what's happening with the program. You can also see what's happening with individual residents. Where does this resident need more work? Where are they from completing their required aspects at this point in the year, and individualized feedback and motivation that comes out of this. So what are we trying to motivate them for, and what are we trying to drive them towards? And that is really certification of competency. And that is, again, what you can't do in a 2-day course, what you can't do in a certificate program, and why internal medicine residencies have a really important niche going forward in this movement. And in the absence of societal certification guidelines, like there are for emergency medicine, we have our internal IMBUS certification criteria that we do here. And how we do this is we take a group of learners over time. This is how these were developed. And we said, all right, let's take a number of 25. And let's say, for example, this is moderately reduced LV systolic function. Let's use that as a theoretical quantity cut point for certification. Now let's go look at this group of trainees after they've done 25 moderately reduced EFs and see if they're truly competent at the bedside to do moderately reduced EF. And with that initial sort of out of a hat number, 92% of people were not competent after having done 25. They go on, they do more exams, and then we reassess them at the bedside. And over time, you land on a number at which 40, in this example, not everyone, but the majority of people are ready to be green stamped when you go and assess them in person at the bedside. And that's a nice way to have an efficient system that's not purely quantity-based certification, which we all know has tons and tons of issues with a pure quantity base. So this combines a little bit of a mastery assessment at the bedside with a quantity sort of based efficiency. And you can see it's not 100%, and that's important as well. It picks up people who are really struggling and who need some more right at the bedside mentoring. You'll see in the handouts for this talk, there's a certification letter IMBUS example. This has been sent to many, many, many different places, so I thought I'd put it up here as a resource that you can grab. When our residents leave, they leave with a certification letter from the IMBUS program. In this are all of our exam count requirements at which they're assessed. And then in it, it shows in this bottom picture here how many days it took them to get to certification in each of these areas. The key here in this example is there's nothing here that's 10, 20, 30 days. This is a year's process in residency. All of those numbers are from months to a couple years there that you see for when they get certified. Machines need to send images. So all of our machines in-house send wirelessly to a central image archiving location that allows us to look at these things in attending rounds. It allows us to pull up an image when a cardiologist wants to see what it looked like last night before they were tachycardic, whatever that might be. Machines need to be able to archive images. Where those images are archived can be a multitude of different options. They can be saved on a USB stick and put on a computer that people can get to. I think the ideal is something that's accessible to everyone. We use a PACS system that isn't our core hospital PACS system, and that's in part because we started this 8 years ago, and there was a lot of resistance to that idea, but it's also nice just to have an educational PACS system where these images go, but also a spot that you can say, yeah, let me show you to the cardiologist, the clinical ultrasound at the bedside. So this is the PACS system we use. Other things to think about when you're thinking about how to archive images. Think about making this a little bit of an educational archive as well. We have a huge set of labels that we've developed that get added to each of the studies that come in, so that if you want to see 50 LV systolic functions that are 40 to 50, you just click on that label, and all of the study that have EFs 40 to 50 will pop up, and it acts as a great learning resource and source for conferences and talks. This is a skill that, quite honestly, we replace other physical exam with, and the idea that you're going to be just as good at percussing the liver in a training program that does robust point of care ultrasound as you would have been if you were in a program that did no ultrasound. You're probably better at a place that does no ultrasound at percussing the liver. So if you're going to sort of acknowledge that reality, you have to support this as you would physical exam from a training standpoint. That means being able to have oversight 24/7, 365, right? And that is a big faculty ask. So you've got to have some way to be able to communicate when faculty are not in person. There's a lot of options out there. Just FaceTime, which brings in PHI sort of questions. There are software pieces that let you see live what's going on with the probe and see the image next to it from remote. The way we do it is a way that if I'm sitting on the dock here in Wisconsin with the kids fishing, I'm in the middle of the woods and someone's got a question that can't be answered and it needs to get to me, they jump on to the imaging archive here, and it's not really 22 in St. Paul. They'll go down, they'll select the image, they'll select some pieces out of the study that they want to send, and then they'll grab one of the faculty names, they'll type in a little message and hit send. And then on the dock in the middle of Wisconsin, this will pop up to my phone. I'll click on it, I'll click on a link, and then 10 seconds later, I'm in the middle of nowhere in Wisconsin. I can look at something they just did at the bedside. So however this gets done, realize that you have to support this from a faculty safety oversight standpoint. All day. It can't be an 8 to 4 Monday through Friday sort of endeavor. We can do a whole talk on machines. Machines of everything are really, really tied to how you do stuff at your place. Whether they are stand-based machines, whether they're handhelds, whether they're tablets, whether they're laptops, most of the time it should be a combination probably of a few of those different types of machines. But there's tons and tons of machines out there, and that decision as to what makes sense is really up to discussion sort of from within and the local resources. What I will say is where those machines are important to think about. On the far left of this image, you'll see a machine sitting on my desk behind a locked door, which is how things kind of started. And then we said, all right, we got to get these a little closer. Let's put them in a locked cabinet down by the residency locker room. And then we said, all right, let's make a little parking spot next to the code cart on every floor and put it up there so that someone comes out of a room, they can see it. And over time, if you look at resident use, it directly correlates to the proximity of the machine to the bedside. And if getting residents to do this is one of the biggest hurdles from a time and motivation standpoint, proximity of the device to where they're seeing their patients is really important. We've moved one step further and put tablets into our team pockets, one on each team. And you might think that look out the door and see that machine down the hall versus in my pocket shouldn't make a big difference, but it actually has another step up in how often they use it. Just because it's on their person when they think about it in the room, they don't have to leave the patient. Don't have to leave the patient, but a machine can lose track of its parking spot. So all of our machines in-house here are tracked. They have little tracking devices on them, and it's not something we did. Every hospital's got a tracking system to be able to find IV poles and IV pumps and refrigerators, etc. So this is just taking our hospital tracking system and being able to add it to the ultrasound devices. So if someone left it in a room and someone else needs it, you can log in and see exactly where that machine is and which room it's sitting in within the hospital walls. If the machine leaves the hospital and is taking a ride down Chicago Avenue on the 21A, GPS ability of the device is also important. So being able to find things, especially as they get more portable, are a really important consideration from putting together an arsenal of machines for your residency program. In clinic, it's a different consideration. You don't have to go up and down floors probably. You can have bigger machines, cart-based machines. We don't have any small machines in our clinic just because we've got a dedicated ultrasound room and you can wheel something down the hall. So you can get away with a bigger, less portable, and diagnostically a little prettier machine. Almost there, guys. Couple other little pieces. We touched on this earlier, but there are so many resources out there now that are web-based and that are available and that are free to use and to teach with and to use as resources to not totally rebuild the wheel. If you can centralize those somehow for your residency program, for your faculty and your residents, it's a really nice thing to do. This is the IMBUS homepage here, and I put this up because under the IMBUS Advanced tab, this is the outpatient textbook that we've written. It's sort of an advanced point of care ultrasound textbook for internal medicine and has a lot to do with our outpatient workflows. This is all free and it's up there. And I point you to that as a resource that you're welcome to use. Other things like how to use machines, how to remember how to archive an image, all of those things, videos and recorded lectures. If you can centralize that stuff for people, you'll realize that in downtime, as long as there's some headphones in the resident lounge, people will log in and be listening to that rather than a talk show. 2 slides left, and these are meant to address a couple questions that usually come up, one of which is, how do you guys document? And this is a multitude of options depending on where you are and what your philosophy is and how you want to approach this. This is how we do it. There's not a separate note that someone did a bedside ultrasound. This is philosophical, and at the start it was somewhat political, but this is how we do it. It's just part of our physical exam. The fact that there's a bunch of mitral regurg and the LV systolic function was grossly normal sits right next to a 3 out of 6 systolic ejection murmur, for example, and right next to edema. So this is just part of our physical exam, and it's how we approach it from a teaching standpoint and from a clinical standpoint, and somewhat philosophically. So there's a lot of ways to do this. There's a whole talk on billing and what requirements come into effect if you're going to bill. We don't bill for any of this from from a physical exam standpoint. We bill for our procedural guidance, but we approach this as a really good physical exam for our patients, and don't think of it outside of that. Finally, there's that day in June when residency program directors say goodbye, and you care a ton about people who have spent 3 years with you, and you feel somewhat of a sort of Jerry Maguire ownership to where they go. So when residents are negotiating contracts, we have a very integral part in that, as to we've trained you with a device that if you don't have it, where you end up, and by don't have it, I mean the political aspects of that, the machine aspects of that. If you end up there, you're not as good of an internist, whether you're a fellow, whether you're a primary care doc, whether you're a hospitalist, without this tool. Because in all honesty, we have replaced some other physical exam skills with this skill. And if you don't have it, you can't take as good care of patients as you would with it. So we make sure that this is part of their contract. This is part of the negotiation, and we really try to help navigate that for them when residents are leaving us at the end. It's sort of a goodbye present from the IMBUS program. That'll change probably 10 years from now, but in the current state, it's an important part to think about. So in the end, hopefully that gives you some ideas, some building blocks to say, how would we make this work at our place? It's not a recipe. It shouldn't be a recipe. It shouldn't be ACGME saying this is exactly how you should run a residency. It should say what makes sense where you are. Analyze your place and where your residents go, and come up with something that really makes sense. Because this movement from medical schools to GME to ACP and SHM and fellowships on the other side of this, it is moving quickly. There's support all around. I assure you there's support and guidance coming from within the GME community, from AIM, and guidance from internal medicine residency. And it's really, really key. The movement can't move to a really safe and high quality outcome without us filling in this missing link, because we are the best venue to train internists to competence, because it takes time, it takes being at the bedside, and it takes learning this with someone at your side on your own patients that you're taking care of clinically. It can't be in an artificial environment, and there's just not a lot of places other than residency where that can get done. All right, that's a lot of me talking. Left a handful of minutes here for some questions. So I'm happy to entertain anything that's out there. Let me peek here at what's come in.
And because we can only take a few, go ahead and pick which ones you think are most relevant to the grand audience.
Yeah, so let me say there's a question financially, how do you fund such a large program? And we fund our faculty from within the Department of Medical Education. We pay our faculty time for mentoring. We pay our faculty time for training. It's something we've done from the start, because the 65-year-old director of medical education, who now does ultrasound every day in our outpatient clinic and teaches, thought that's how you should do this if you really wanted to develop a faculty. So financially, machines, tapping into your hospital foundations. This is a great new innovation that improves patients' care, satisfaction, safety, etc. Is a recruiting device, because medical students are looking for this. Foundations are often very interested in helping fund those aspects. Is there such thing as an online POCUS fellowship? The answer is no. I'll answer that one because it's quick. Do you archive and review POCUS images that the residents take? I touched on how we do it. We don't archive every image here. That differs from place to place. If I just go and look at an IVC real quick on a patient who I gave a liter of fluid to, and I want to see what's it looking like now, or if I go look at an LV that was hyperdynamic to do the same, I don't necessarily clip an image and save an image for that. Our residents are mentored at the bedside and don't do them without oversight until they're certified. So all of that overreading that's often tied to saving every image doesn't happen here. If the residents have a question once they're certified, if they're doing something they want to save for a case conference they're going to present, et cetera, if they want someone else to look at something or a cardiologist who's coming in 2 hours to look at something, we archive those images. But that's a local decision. You need to have the resource available, but to archive every image outside the world of billing is not an imperative directive. I touched on how we certify residents. That's in here. The IMBUS tracking application available publicly. It is. We had a software company mobilize it to a web-based platform a handful of years ago. I can send you the information on that. If you send me an email, I'll send you the specifics on how to get that information. How this rotation is attributed. So the 2 rotations, the outpatient ultrasound rotation is 100% ambulatory attributed, and the inpatient procedure and ultrasound rotation is 100% inpatient attributed. Someone asked how those 2 rotations are attributed from a inpatient outpatient standpoint from a residency piece. And there's let's see, one more here. It says, had a question about image archiving. Was there ever a time when you didn't rely on a cloud system and downloaded images using USB sticks only? Do you think that was a big barrier? And we did at the start. And the barrier was the cardiologist who wanted to see it or passing things along from one provider to the next, a pneumonia that should be improving or pulmonary edema that should be improving, and to go, and no one ever went to look at an archived image on a USB stick, I think is a fair statement there. So the USB stick met sort of this theoretical, you've got to archive mentality, but really didn't provide any safety or benefit or communication. And it really wasn't until we made a platform for archiving images that was available on any computer that could hit the cloud that it actually became a clinically important archive.
Okay, well, it's a little after 2, so we're going to have to call it a day. Thank you very much, Dr. Tierney. And on behalf of the AIUM, the ACP, and SUSME, our thanks to all of you who participated in today's webinar. Please remember to complete the post-test and the activity evaluation, and we hope you enjoyed this presentation and will join us again in the future. Good night, everyone.